I'm Carmen Barbas, Associate Professor of Medicine from Brazil, and in the next 50 minutes, I will talk with you about how to optimize PEEP in ARDS. ARDS is characterized by a bilateral lung infiltrate that during less than 7 days, no evidence of cardiac failure or hypervolemia. The risk factor have to be diagnosed and treated, and it has various degrees of severity and mortality. Normally, the moderate to severe ARDS, the patient have to be intubated and mechanical ventilated. The tidal volume less than 6 ml per kilo of predicted body weight, PEEP of 10, and we get a gasometry. And if it's less than 150, we normally prone the patient because of the ProServa trial and try to do a protective ventilation with a PEEP optimization and low driving pressures. Normally, when the patient is having ARDS, they have a reduction in the tidal volume, a reduction in functional residual capacity, with a very heterogeneous lung. Then when we mechanically ventilated this patient, you can have ventilation-induced lung injury with hyperdistension, shear stress first, and collapse and reopening of the airways. So to minimize this, you can decrease the transpulmonary pressure, decrease the driving pressure, or decrease the strain, decrease the tidal volume, or increase the FRC with prone position or PEEP titration. It's well known in the intensive care world that when the lungs is accommodated by ARDS, the PV curve of the respiratory system shifts to the right and to down, and with very low compliance sometimes of these lungs, and you can ventilate these lungs in the security window. In ARDS, the patients in the supine position, they can have a lot of collapse in the bottom part of the lung, and sometimes a high abdominal pressure can involve the lung, and you can decrease the lung volume, worsening the patient condition. Recent meta-analysis analyzing the lung protective ventilation in moderate and severe ARDS only showed significant improvement of survival relating to high tidal volume in the low VT prone position, and trends with ECMO in the more severe patients, and with high PEEP and low VT versus low tidal volume, a trend to improve the survival. But what we can say about these trials, it's different strategies, different populations, different severities, different patients' position, different risk factors for ARDS, different SOFAs, and different risk factors for death. In the real world ICU, when you have the patient with ARDS, a lot of things interfere and they can be confounders of the situation. The patient have different cardiac functions, different abdominal pressures, different abdominal pressures, different ARDS severity, different fluid balance and extravascular lung water. And the patient can be sedated and paralyzed or have inspiratory efforts, different renal functions and shocks. So during mechanical ventilation, you have to characterize that the patient that have a low tidal volume, the respiratory rate, adequate one, the PEEP titration that we are going to see, and the gas exchange, and avoid asynchrony. And you have secondary infection change of the situation over time. So with thoracic tomography, we can see that during RDS you had a lot of collapse in the bottom part of the lung. And if you tritate PEEP adequately, you can open the lung at the bottom, recovering the lung function, and the infiltrates, the infection stay here, and the collapse can open with tritated PEEP. You can improve the aeration, the compliance, the oxygenation of the patient. We can do it with PV curve, tritate the PEEP after the inflection point and ventilating this best compliance part of the curve. We show that it's impacting in the mechanical ventilation in this ARDS trial in 1998. Our group showed that tritating PEEP and ventilate with low tidal ventilation can improve oxygenation compliance and lowering mortality. And in this paper, we showed that independent of tidal volume, you can improve the mortality with high PEEP levels. This was confirmed by another trial of Jesus Villar and Bob Kazmarek that showed the same results in 95 patients, showing that low tidal volume and high PEEP in the inflection point can improve the survival. Another way to tritate PEEP is with the PEEP FiO2 tables. The Alveoli trial in 2004 showed that two different tables can lead to the same results in survival. Good survival with a low PEEP, higher FiO2 PEEP table, or higher PEEP, lower FiO2 PEEP table. But this trial showed that two different tables can be used to tritate PEEP, and they have similar results. But you have to tritate PEEP. See that with low FiO2, we have lower PEEP, and all the tables, the two tables, they used higher PEEP with high FiO2. Another way to tritate PEEP is through the esophageal catheter. In 2008, the Talmor group showed that tritating PEEP with the esophageal pressure, the transpulmonary esophageal pressure 0 or more than 0, we can improve the compliance, improve the oxygenation, and in 61 patients, they showed a trend to improve survival. But after, in 2019, with more patients, they showed no difference in mortality. But we have to criticize one thing in this paper, that in the 2008 paper, they compared the esophageal guided ventilation with the control group, the table. They used higher PEEP after 70% of FiO2, but in the paper of 2019, they used higher PEEP after 0.4 of FiO2, and this PEEP table, they use a higher PEEP, and that's maybe the reason that they didn't show difference in mortality between this higher PEEP table comparing to PEEP guided by esophageal pressure. In 2012, we published this paper, our group, showing that you can recruit the lung image-guided recruitment in the tomography, showing an improvement in PO2 with a low mortality of the 32% of these severe patients with no complications. Here we show that you can decrease the lung collapse, increasing the normal lung at the tomography, and you have to tritate PEEP to keep the open lung with low atelectasis, and if you decrease the PEEP to 10, you can increase again the atelectasis. In the COVID time, we have a lot of different lung accompaniment with a lot of ground glass and uh, uh, organizing pneumonia, turning more difficult to titrate PEEP and do a protective ventilation. So you can use the impedance tomography. Our group have a lot of experience with that. We can see the lung ventilation, if it's okay right in the right and the left lungs and the upper and lower lung. You can titrate the PEEP with the PEEP titration tool you can titrate people with less collapse and less hyperdistension. You can see in the map, you choose the PEEP in this less collapse and less hyperinflation window. And we have to do more studies to see the impact of this in lung in ARDS survival. Uh, lung ultrasound can be used. The group of Claude Guérin showed recently that you can use the ultrasound. This is 24 patients that they use the LUS score and the recruitment inflation rate to titrate PEEP, and they see a good correlation between LUS reaeration score and recruitment to inflation rate, comparing PEEP of 5 and PEEP of 15 in these ARDS patients. Our group, we use the lung tomography with impedance tomography, and we have to do more studies to see if titrating with more detailed the PEEP and the tidal volume can improve the survival of the ARD patients. In conclusion, ARDS patients include COVID-19 patients. We have to do a protective ventilation with low tidal volumes and low driving pressures. And you have to use prone position when the PO2 FO2 is less than 150, and some in the COVID patient may be 102, below 100, below 200 PO2 FO2 ratio, and we have to do more trials analyzing the PP optimization with PV curves, so PP FO2 tables, at bedside impedance tomography, lung ultrasound. And we have a lot of experience with thoracic tomography that I'm sure we can improve the knowledge of what is occurring with these severe patients, and you can plan a more protective mechanical ventilation. Thank you very much.